We now prepare to incise the pericardium. For orientation, we show here the right border of the heart. We show the ascending aorta and the pulmonary trunk. We show the left border of the heart and the apex of the heart and the attachment of the pericardium to the central tendon of the diaphragm. For our incision, we make a midline incision and two horizontal incisions. The inferior horizontal incision is just superior to the attachment of the pericardium to the central tendon, and the superior incision will be just above the origin of the aorta and pulmonary trunk. When we reflect laterally, we will take care not to damage the phrenic nerves, which we indicate. We have now incised the pericardium, and for orientation here, we show again the outer or fibrous layer of pericardium. We reflect it laterally here and show the shiny serous layer of the parietal pericardium. We reflect the pericardium on the left and show the shiny surface of the heart covered by the visceral layer of serous pericardium. And there's a small amount of fluid between the parietal and visceral layers that help to lubricate the heart as it beats. This is an anterior view of the surface of the heart. We note that most of the anterior surface is composed of the right ventricle, which we compress here, and as we move to the left, we press on the left ventricle, and note that its wall is very thick. The left ventricle forms the apex of the heart and the left border of the heart. This view is similar to the cardiac silhouette that you'll see on a PA view of the chest. We now have a view of the left surface of the heart. We identify the left ventricle and the apex of the heart, and we identify the left atrial appendage and the ascending aorta and arch of the aorta. We show the pulmonary trunk and the left pulmonary artery. We see the ductus arteriosus connecting left pulmonary artery and arch of the aorta, and we show the left recurrent laryngeal nerve hooking around the ligamentum arteriosum to run posterior to the aorta to supply the larynx. We've removed the fibrous pericardium from the right side of the heart, which allows us to see more detail. We re-identify here the right main stem bronchus, the right pulmonary artery, and the superior pulmonary vein. We identify anterior to the hilus. We show the superior vena cava, and we can see the arch of the azygos vein entering the superior vena cava. We follow the superior vena cava inferiorly. We can see that it enters the right atrium, whose borders we now indicate. We show the right atrial appendage, and inferiorly we can see the inferior vena cava piercing the diaphragm to enter the right atrium from below. We now re-identify here the right ventricle and the ascending aorta, and we identify the atrioventricular groove where we will locate the right coronary artery. This is a superior view of the heart and the mediastinum. We have our probe in the transverse pericardial sinus. We identify the ascending aorta and the pulmonary trunk and show that the pericardial sinus separates the outflow tracts of the heart from the inflow tracts. We now have a left view of the heart. For orientation, we show the ascending aorta, and we show the diaphragm on the right and on the left. And we placed suture in the apex of the heart so we can retract it. We now retract it laterally to show the diaphragmatic surface of the heart, the posterior portion of the pericardium, and the base of the heart. With the heart reflected laterally, we can identify the left ventricle and the atrioventricular groove. We can identify the left atrial appendage and the left pulmonary vein, the left atrium and the right pulmonary vein, the inferior vena cava, and the right atrium. We now identify the serous layer of the parietal pericardium, and we can see where it's reflected onto the left pulmonary vein as the serous layer of visceral pericardium, and it continues onto the heart as epicardium. We can also see where the inferior vena cava has pierced the central tendon of the diaphragm to be covered by visceral pericardium. We've removed the pericardium from the base of the heart. We identify here its cut edge, and we can see posteriorly the descending aorta and the esophagus. We re-identify the left atrium, and as we put the heart back in position, we note the close relationship between the left atrium and the esophagus. We can exploit this relationship in performing a transesophageal echocardiogram.